for he is one of the alumnus of ICH, and he had completed his DCH from this institute. So over to Dr. Shane uh, for the
Thank you.
presentation today.
Thank you. Thank you so much. I mean, it really is quite an emotional day for me, which is strange because usually by the time you come on to present something, you are very emotionless and factual and you talk about it. But today when I see audience, I can see Apurboda there, Ritaprata, I saw Mayadi is there, Dr. Gautam Ghosh. It's like, oh my God, all my bosses are there. And it's very difficult for me to talk after that because whatever I am, whatever I have been or become, whatever I might be, is only because of blessings of people like you. So thank you all. Seriously, thank you. Seriously. আমি বাংলায় বলছি, যখন আমরা আইসিএইচ এ শুরু করেছিলাম গত বছর আগে, তখন মায়াদি, অপূর্বদা, ঋতব্রতদা, Dr. Gautam Ghosh, my whole introduction to the world of pediatrics and my guidance into this world started in their hands. So I feel very small, very insignificant when I think আজকে বসে I'm doing a presentation and you guys are listening. So thank you and pranam. Really, that's my thank you. So as you heard, আমি ICH থেকে শুরু করেছিলাম with my pediatric training, তারপর DCH করার পরে then I
So
after a few
Santanu, it will go to YouTube. So you speak
okay.
only in English.
Okay, so after my training in Institute of Child Health, I basically after a couple of years I went over to London, and this picture is of my second training in hematology, which happened at the Royal Free Hospital. And then after spending about 2 years there, I went over to Newcastle. This was the Royal Victoria Infirmary right at the top right hand corner. And this is where I kind of learned all that I know today about bone marrow transplants, stem cell transplants. And I was fortunate enough to have been given the chance to work there for 3 years. And then I moved down to London again to the Royal Marsden, where I spent, where at the Surrey site and the London site of the Royal Marsden, St. George's. I spent close to about 5 years. And then as you know, I came down to Bombay and started the transplant unit and the pediatric hematology unit at Kokilaben Dhirubhai Ambani Hospital, where I have been for the past few years, 12 years now. So what I thought today is that we'll be talking about thalassemia, and we'll talk a little bit about the background, not much about prevention, diagnosis, treatment, bit about transplants. And I thought I'll get a little bit in about gene therapy because it's very topical. People are very interested in it and they want to know how things are going, what will come. So if we talk about the background, we know this, especially for residents who are listening into this, we know that this is a genetic disease. There's a genetic defect. So hemoglobin, as you know, is made out of two chains, alpha and beta, if you look at hemoglobin A. And these are chains, so that we know that the genes that are responsible for the synthesis of the alpha and the beta chain. The alpha chain, the gene is on chromosome 16. The beta globin chain is on chromosome 11. So if we have either a point deletion or a point mutation in any of these genetic sites, we would have a defective synthesis. Now, how much of that will be resulting in a clinical condition can run the entire gamut of being completely asymptomatic, which is what happens in thalassemia minor, to completely fatal, which will happen if you have absolutely no alpha gene synthesis at all. So hence you can have alpha thalassemia, which can be that you have alpha 0, which basically is where you have a child with high drops fetalis, you have no alpha globin chain synthesis, which means all you have is a little bit of beta tetramers going around, which is incompatible with life. And these are the young lives that are snuffed out very early. They die in utero. And then you have the slightly reduced where you might have one beta globin chain that's defective, which means that that is completely compatible with life as normal. They might have a slightly low hemoglobin percentage. And finally, you might have a beta thalassemia major, or what is also called thalassemia major, which means that you have absent beta globin gene synthesis, which means that you have the typical hemoglobin A of alpha 2 beta 2, which means that the blood has to be of other hemoglobin types, which can be either the fetal hemoglobin percentage will go up. So if we talk about incidence, I love showing this chart because this shows where thalassemia is. And you can see this is what Thalos is. This is the Mediterranean belt. This is from here down the entire end. We see all the countries that are affected in a major way by thalassemia major. And it's quite interesting to think that this is probably due to migration of somebody who was carrying the defective gene down through the ages, and that's how it had spread. And we can see countries that are affected are the ones around the Mediterranean, Upper African, Middle East, down to India, and then further down the south. But we know that in India, we have a massive problem. We have the largest number of cases anywhere in the world. That's more than 30,000 new cases per year. And there are certainly communities, Gujarati, Sindhi, Punjabi, Bengali, where the number of cases is very high. Now, even though I showed you that entire thalassemia belt, that's probably not exactly where the maximum cases are, where there are maximum cases, but that's not the only place where the cases are at present. And that's because we are seeing a massive amount of economic migration in the last 15 to 20 years. So which means we have more and more people from India and these parts, it's a global village, they are going all across the whole world. Now, I think that's a very interesting point because the first time when I became interested in thalassemia, when I was still working initially in the UK, I had my boss who was a South African gentleman called Henry Blumenthal. And he used to say that the reason that there has been no new drugs or no new treatment for thalassemia is because USA doesn't have thalassemia cases. Well, that's no longer true because now with migration, they also have a number of thalassemia patients. And that's very interesting because newer drugs and newer treatments are now coming out one after another. And I think that's a very interesting point that's happening. But going on, so we talked about this genetic mutation and how does it happen? So with a normal person, if you look at this figure, this is what a normal hemoglobin looks like. We've got the four heme moieties in the center, and these are surrounded by either two alpha and two beta chains. Somebody like that is normal. Now, suppose we all inherit one copy of our globin chains from each parent. So we'll have one copy of our beta gene from father, one copy from mother. But somebody who is a carrier who inherits only one functioning copy with the other copy being defective would be somebody with thalassemia carrier without illness, but a slightly less hemoglobin. Now, should we get a child who has both copies of the globin chain being defective, this would be the child that will end up with a very severe anemia because we no longer would have any proper hemoglobin synthesis with alpha to beta 2. To put that into another perspective, so this is what we know that before birth, the maximum amount of hemoglobin that's in the body, the majority is the hemoglobin F or fetal hemoglobin, which is made out of two alpha chains and two gamma chains. The gamma chain synthesis drops off after birth, and the beta chain synthesis normally starts off at about 35 weeks and hits a peak around about 8 weeks after birth. And this is the switch that we normally see that before birth or in the neonatal period, fetal hemoglobin, even up to the age of 1 year, fetal hemoglobin is the majority of hemoglobin that we see. But somewhere after birth, the fetal hemoglobin percentage would go down and the majority hemoglobin that we'll find is hemoglobin A, which has two alpha and two beta chains. But should we have a child with thalassemia with absent beta chain synthesis, what we'll find is that this child will become symptomatic somewhere in this age group of about 18 to 30 weeks. So basically around 4 to 5 months, the child would become increasingly anemic. And that is why we find that the patients are picked up somewhere around the 6 month period, because that's when they become increasingly anemic. They have growth failure, and they basically start developing hepatosplenomegaly. Pathophysiology, I'm not going to talk a lot about, but it's important to know it's not just low hemoglobin that causes all the problems. Because what happens is that with decreased hemoglobin's production, you don't have enough beta globin chains. The alpha chains form tetramers, and these form unstable tetramers, which precipitate as inclusion bodies in the hemoglobin molecule. So the spleen actually takes these up and hemolyzes them. So on one hand, you have defective hemoglobin production, less hemoglobin production. You have defective hemoglobin production that is secondarily hemolyzed by the spleen. And all of these results in expanded marrow cavities. Why does that happen? It happens because the body desperately tries to make more and more blood. And so what it does, the marrow cavity starts getting bigger, and that's why you have that typical thalassemic phases with prominent malar prominence that develops if the patient is not given enough blood. It doesn't stop there. The body tries to make blood elsewhere. And so what you have is the extramedullary erythroid hyperactivity, which results in the liver and spleen getting big. You might get some degree of lymphadenopathy. And sometimes you might even get this extramedullary tumors, which can be seen on the chest. So all of these, so what you have severe anemia, you have defective blood production, you have hypoxia, but the body still feels that it needs to make more blood. And what does it do? It increases gut GI iron absorption. So which means it's a double whammy, because on one hand, we are giving transfusions, which leads to excess iron accumulation. And on the other hand, the body itself absorbs more and more iron from the gut. So it's not surprising the ferritin goes up exponentially. And it's not just a question that it's coming from destroyed blood, it's also coming from the body itself. And what does it do? This iron, it gets spread through the body not as a free labile plasma iron, which generates reactive oxygen species, which means that these oxygen species cause eventual tissue damage and death. So without, or rather with inadequate treatment, the usual lifespan traditionally of a child with thalassemia was a death from a cardiac event somewhere in the second decade of life. And the main reason for that cardiac death was arrhythmia due to excessive iron accumulation in the cardiac muscles. So which means iron chelation has always been the only solution for this. Whatever I've said is basically this is what it shows, that you have reduced beta globin gene synthesis, iron, the alpha globin tetramers are there. These are taken up by the spleen and destroyed. You have expansion of marrow cavity, increased iron absorption from the gut. And this, in a nutshell, is what your clinical features of a thalassemia is going to be. So if I take a deep breath and talk about the genetics of it. So normally we know that we inherit one copy of our genes from either of our parent. So if both parents have healthy genes, we have healthy parents. Now take a minute and think, if one of the parents has a defective copy of the beta globin gene. So he or she has one working copy, one defective copy, which means that he or she will be fine physically. She will not have any medical needs. She might be slightly anemic, but would be otherwise well. But she is a thalassemia carrier. Now, she marries a normal person, but that one defective copy of the gene would be transmitted to 50% of her offspring, which means that 50% of the children would end up being a carrier for beta thalassemia. And this is what we see. Now, if by any chance both parents carry a defective copy of the gene, then 25% of the children would be unfortunate enough to inherit both the defective gene copies, which means these are the children that have thalassemia major. 25% will escape being completely healthy, and a 50% would have one single defective gene copy, i.e., they would have a thalassemia trait or thalassemia minor. They will be normal, but being carriers of the defective gene, they will also in turn transmit the gene on to the next generation. So this is where our entire prevention talks comes in, that we need premarital counseling, screening. We do screening for school children to try, college children to find out whether they have thalassemia minor, and talk to them that before marriage and certainly before pregnancy and before delivery, it's extremely important to know whether the mother to be is carrying a thalassemia gene. How do we diagnose? So when I was studying, we used to call it that we need a hemoglobin electrophoresis. The same thing we do now on what we call as a high performance liquid chromatography. And what it does, it basically elutes the various, I'll just go to the next slide. It elutes the various hemoglobins on a platform like this, on an HPLC platform. So what happens is when we see a chart like this and we see, so I would cheat and look at this figure out here, which says what are the peaks that we are seeing. So in this figure, I can see that the fetal hemoglobin peak shows 95%, whereas the hemoglobin A peak is almost zero, and the hemoglobin A2 is about 3.94%. So this is the hemoglobin electrophoresis or the HPLC from a patient who has almost zero hemoglobin A, which means they really don't have any beta chains at all. There is some amount, there's excess of fetal hemoglobin, alpha 2, gamma 2, and a bit of hemoglobin A2. Now, look at this chart. Sorry, I'm going back. So this is somebody whose fetal hemoglobin is about 8%. Fetal hemoglobin A is about 77%, but hemoglobin A2 shows a higher peak than normal. So remember this figure that the normal range of hemoglobin A2 is between 1.7 to 3.2%. Any value over 4% indicates that this is a patient who has thalassemia minor or is a carrier for thalassemia. Anybody whose hemoglobin A2 values are between 3.2 and 3.8 should be considered borderline. Ideally, we would want to have another check after 6 to 8 months to check whether that is truly a carrier or not. I'm going back again. But whenever we do an HPLC, there are a few things we need to keep in mind. One of the more important things is that we have to ensure that the patient must not have had a transfusion in the past 3 months, because any results that we do post-transfusion really cannot be interpreted, because we can't say how much is his own hemoglobin that we are seeing on the machine, how much is the transfused blood. The question that comes very often from my juniors and other clinicians as well, that suppose you're faced with a child who's been seen somewhere in the periphery who presented with a very low hemoglobin, 3 grams, 4 grams, and was given a blood transfusion. How do you diagnose the patient? And there are some ways to do it. Number one is you check both the parents. And if we find that both parents are thal minor, then the most likely diagnosis in that child is thalassemia major. But if we really want to be certain, we want to know what it is, then we can do genetic studies. And what genetic studies can we do? So we can actually either do a genetic mutation analysis of the parents, which is taking it one step further from an HPLC, and we can do a genetic mutation analysis of the child as well, looking at the common genes that are responsible for causing thalassemia major. And then we compare these three results. And if we find that parents have a genetic mutation in the loci, which is well known to cause thalassemia major, and the child has actually inherited those, then the diagnosis is done. So more than 200 genes responsible for the disease has been identified, and we know the common mutations that are found in thalassemia patients. So which means that when we do the test, we can actually check for these 7 to 11 genes that are the major cause of thalassemia major. And this is done by a molecular analysis with a PCR. But we have to remember, because we have chosen the majority of genes that causes the disease in more than 90% of patients, in 10%, the defect might be in a gene that we are not testing. So even though it's very good, it's not 100% infallible. So can we do anything more than that? Well, nowadays on the next generation sequencing platform, we can do a full gene sequencing for the entire hemoglobin beta gene, which is quite a cumbersome, quite a big task, but it can be done. But like any other new technology, it's not infallible, because it may not reliably detect some mosaic variants or very large deletions. So I think the best is to do an HPLC and then look for the common gene mutations, and that way we can pick up the majority of our patients. I just put it there that suppose we have a patient and the parents are find out a few years later the mother's pregnant, and she doesn't really want a child with thalassemia. How do we handle that? And this is a question that we ask our residents quite often. And this is what we really should be talking about, which is doing a prenatal genetic diagnosis, so that we don't burden the parents with yet one other child, bring up one more child with thalassemia major. What do? We can do a CVS in the first trimester or an amniocentesis. And now we look, again, it's the same theory. We look for the genetic mutations that are there in the parents, see if that's there in the child, and look for those genetic mutations by doing the prenatal genetic diagnosis. The issue is that sometimes you might have a fresh mutation coming on. So which means if our prenatal genetic diagnosis says that the unborn child has thalassemia major, it means we can advise them that, sorry for just a second, we can advise them that they should not continue with the pregnancy. However, it's not infallible. And this has happened to me as well. I had a parent which very well-to-do family. One of them was a CEO of a software firm. Wife was again somebody equally high, and they knew that both of them were THAL carriers. They were very well-read, and they actually identified the genetic mutation in both the families, and they did the prenatal genetic diagnosis. And when we did that, we could say that the genetic defect that was in the mother was not there in the unborn child. The genetic defect in the father was not there in the unborn child. But when the child was born, we had an absolute horror scenario, because the child had thalassemia major because he had a new mutation. Now, the reason for the story is that sometimes this is what happens. We get mutations which are fresh. So if it's positive, we can certainly say that the child has thal major. If it's negative, we have to say that we are 95% certain that a child doesn't have thalassemia major. We cannot say about that balance of 5%. So we're still talking about a child with thalassemia major, and we are going to give this child blood transfusion. It's a question for the residents basically, that whenever we give blood transfusions, what kind of a blood we want. We really do not want whole blood. We want really PRBC or packed red cell transfusions. But ideally, we want it to be of such that causes least amount of reaction. In a slightly resource deficient setting, even then the minimal we would be looking for is blood that is saline washed. What saline washing does, it really reduces the risk of allergic transfusion reactions, because it reduces the immunoglobulins such as the surface IgA. But if you want something a little bit better, we would want leukodepleted blood, which is where you have an inline filter, also called PAL filters. And this is really good to reduce febrile reactions. It also reduces the risk of CMV. And if we want to go one step further, which is somebody says, what's the best kind of blood I can give him? We would ask for irradiated. And especially when I'm doing stem cell transplants, we want irradiated blood products pre and post transplant, simply because we want to destroy the living white blood cells, because these lymphocytes can cause transfusion associated graft versus host disease, which basically carries 100% mortality. Interestingly, if a patient gets an allergic reaction to blood, then sometimes we find that the best blood to be given to that patient is saline washed, because that is the one preparation that really, really reduces allergic reactions. With my patient we are talking about, we decide to transfuse leukodepleted irradiated blood products. So what are we looking at? And these are again brief things to keep in mind, that when we are transfusing a child with thalassemia, we want to maintain a pre-transfusion hemoglobin percentage of 10 gram percent. And so, which means that when the child comes in for a transfusion, we should do a hemoglobin percentage. At that point, there's no need to do a post-transfusion hemoglobin percentage at all. And we want to maintain that at somewhere around the 10 mark. Not at 8, not at 7, certainly not at 6, which is sometimes I find in some peripheral centers. Really, really keep it at 10. Why do you want it at 10? Because we want to stop extramedullary hematopoiesis. We want to stop the marrow expansion process. If you keep your HP high, you are stopping the iron absorption that happens from the gut. Your ferritin will go down, which sounds counterintuitive, because you think I'm giving more blood. Surely ferritin will go up. No, it won't, because you are stopping more iron absorption from the gut. So very important to keep the hemoglobin high. How long do we transfuse? Transfuse the entire amount over a short period of time. 4 hours is absolutely fine. 3 to 4, you really don't need longer than that. Another quick point, even if you're giving 3 units of blood to a child or 2 units of blood to a child, you can give the entire thing within that 4 hour window period. You really do not need to warm any blood products at all. In fact, a blood warmer has no role to play in a transfusion service center. And you can calculate the dose based on the hemoglobin, and it's something that all residents know by heart, about 15 mLs per kilo, or check the difference between hemoglobin percentage and do it. Very quickly, when and how to start. If it's a new patient, ideally start when the hemoglobin drops below 7. Don't wait for poor growth. Don't wait for bony deformities. What things do we check before we start? We ensure there's no folate or G6PD deficiency. And the second transfusion, we start again when the HP again drops to 7, and subsequently monthly afterwards, and then gradually pushing up the hemoglobin to 10 gram percent or above. This point is important, that we avoid transfusions from parents and first degree relatives, because what happens is if you do that, we run the risk of sensitizing the patient to the similar HLA types that are present in the parents and relatives, and that is what can cause transfusion associated graft versus host disease. I'm not going to go into that. Suffice to say that if you get transfusion of TAGVD, we basically can't really save any of those patients. So really avoid family and related donor transfusions as much as possible. Make sure that we have given hepatitis A and B vaccines. This is what we talked about. Next, we come to chelation. So our patient gets a ferritin checked and they find it's 2200. Should he need any therapy? So if we talk about chelation, what we do is we check ferritin every 3 to 6 months when we start treating these patients. Once the ferritin reaches about 1000, that's usually when I start therapy for my patients. And it's important to try and keep that ferritin at a low level. We have 3 different drugs that we can use. We have desferoxamine, or available as desferal. This is the oldest and possibly the best studied drugs iron chelator that we have. And I still believe it's one of the best chelators out there. After that, we had the first oral chelator that we had, which is deferiprone or Kelfer, and it has got a shorter half-life, about 6 hours, 4 to 6 hours, which means that we have to give it 3 times a day. And finally, a newer product called Deferasirox, which again is an oral chelator, And this has a longer half-life of almost about 18 hours, which means we can use it only once a day. There are subtle differences between these three drugs that we have. Now, desferoxamine, the IV drug, has to be given either as a subcutaneous or an intravenous injection. Sometimes I find patients getting a blood transfusion, and after that, a physician in a peripheral center giving one vial of desferoxamine IV. Now, this is it's basically useless because this drug has got a half-life of about 8 to 10 minutes. And this is the reason it has to be given slowly over 8 to 12 hours. Even now, if we have a patient who has a very high ferritin who's getting into problems with secondary toxicity from ferritin, we put them on desferoxamine continuous infusion, and it's extremely effective. It binds to iron in a 1-to-1 ratio. Majority of the excretion is fecal. We have some auditory toxicity which we watch out for, but otherwise it's a very safe drug. The second drug we talked about is deferriprone, which is the first oral agent that was basically found and came into clinical practice. It needs to be given 3 times a day. This is excellent to chelate cardiac iron. Desferoxamine is great for hepatic. Deferriprone is great for cardiac. It excretes, binds the iron in a ratio of 2:1, 2 molecules of deferriprone to 1 molecule of iron, mainly through the urinary tract, causes some GI upset. The major side effect or problem we need to look out for with this drug is neutropenia and agranulocytosis, which means that any patient that is on Kelfer really should have a full CBC checked. I can't stress this enough because sometimes what happens in many centers, patients might only get a pre-transfusion hemoglobin check done rather than a full CBC. So if a patient is on deferriprone, is on Kelfer, we need to see what is the total white cell count, what's the neutrophil percentage, what are the lymphocytes, so that we can pick up the patients that are getting a marrow suppression from this drug early on. And the third drug is deferasirox, which is currently the drug of choice for most patients of thalassemia major, with a longer half-life of 18 hours, can be given just once daily, and it's excreted in with the stools. Major toxicity is actually GI, can cause a degree of abdominal distension, a little bit of distress. Some patients find it difficult to have. Very important with all of these drugs, especially of deferasirox, is that it tends to get chelated with metal containers. So when we advise parents, we got to tell them that use a ceramic glass or a glass made out of glass, and the spoon needs to be a wooden spoon, which is quite a difficult thing to get, but that's how it should be. Mix it with water and then have it. Deferriprone, if we have it, it's really ideally with apple juice or orange juice. An acidic medium actually helps in the absorption. Minor points to say. But is there any new drugs in the whole plethora of things coming into thalassemia? And this is a new drug that has been introduced in the last couple of years called Oleptis, which is basically the old deferasirox film-coated tablet. Who is it for? If you remember in my last slide, I said deferasirox can cause GI upset. So if somebody is intolerant of deferasirox, for somebody like them, this can be a good option to go for. Basically being film coated, it doesn't break up in the stomach contents per se, but it basically breaks down some a little bit further down in the small intestine. So you have less upper GI distress, less distension. You don't get that much of a discomfort by taking this. But is ferritin enough when we are looking at iron overload? Honestly, it gives you a good idea about what's happening to the total iron load. But if we want to have a very good idea as to what is happening overall, we need something more than that. And again, this might be a question that the residents might get asked, that what else can you do in order to quantify the total iron load that's happening in the patient? We can do a liver biopsy and measure the liver iron, which is very, very effective. On the flip side, it is an invasive procedure, so you can decide whether your patient needs to. As a research molecule, there is this machine called a SQUID, magnetic biosusceptometry by superconducting quantum interference device. It's a mouthful. When it first came about 10 years ago, people got excited that this might be a very good way to measure the complete amount of iron in the body, but it never actually graduated out of the research labs, and there are hardly a handful of this in the research labs around the world. So nobody really uses it. But what all of us use, because almost each and every center would have an MRI scanner. And if you speak to your radiologist, ask them if they can run a T2 MRI image. A T2 MRI image will show up if there's any iron overload in the heart, in the pancreas, in the pituitary. Really important with these two. I mean, of course, you want to know cardiac overload because cardiac iron is what will cause your arrhythmias or dysrhythmias and might kill your patient early. Pancreatic iron overload, you want to find out whether your patient's going into Brown's diabetes, which, as you know, is one of the very typical symptoms you see in thalassemia major. And we often find growth failure and short stature because of iron overload in the pituitary. So T2 star MRI is what we would suggest that every patient should have at least once a year. So what are the regular investigations we ask our thalassemia patients to have? They should have a ferritin at least every 3 months, a liver LFT every 6 months, ideally a T2 star MRI about a year or 2 years, so we can catch which are the patients that are getting more iron overload, and so that chelation can be appropriately increased so that we can give them a proper life. I'll mention splenectomy very briefly because I really don't like splenectomy, but it's a fact of thalassemia treatment because with inadequate chelation and under transfusion, hyperchelation is almost inevitable by 10 to 15 years or 5 to 10 years of therapy, which means that when the transfusion requirements goes to about 20, then a splenectomy will reduce the amount of blood that's needed because then you have less amount of defective hemoglobin being destroyed by the spleen. Important that before undertaking a splenectomy, we give these patients a pneumococcal meningococcal vaccine, and they should be on a penicillin prophylaxis afterwards. Very important, any child, any adult who gets a fever post splenectomy merits an immediate evaluation to see whether he or she merits a hospitalization for IV antibiotics. I kind of stress this a lot when I talk to patients in Gujarat or in Madhya Pradesh, because there you have the other scenario of a lot of sickle cell disease patients who get an autosplenectomy, as you are aware. Plus, they are almost all on hydroxyurea, which means that they don't have a spleen and they already are taking a medicine which causes marrow suppression. And these patients, when they get a fever, they can actually die within 6 to 8 hours. Similarly, back to the thalassemic world, that if your patient has had a splenectomy, be a little bit aware what's what happens to that patient. But everybody wants to know about transplants. So if a patient actually is going to a center where they are being followed up and they find somebody who's having a transplant, they want to know about a transplant, or what we do mostly in the thalassemic world still is called a matched sibling donor transplant, which is that we find if there's a brother or a sister who is thalassemia free and is a complete genetic match for the patient, we can take them up for a transplant. If we don't find a brother or sister who's a match, what other options are there? In those cases, we can do what we call as a matched unrelated donor transplant, which means we look at the various transplant registries to find if there is a donor out there who's a full match for our patient, collect the stem cells and do a transplant. What are the outcome figures for both of these? If we do a sibling donor transplant, with the current results are that we have an overall survival of nearly 90%. Even with a matched unrelated donor, it's almost about 80% nowadays. And the recent figures are claiming a survival of almost 85. So in practical terms, what we say is that if there is a sibling who's a match, or if we find a donor in the unrelated donor registries, these are the patients that should really consider going for a transplant as early as possible. But it's very important to talk to parents to make them or completely explain to them about the whole transplant process, because they have a child who can be treated without going for a transplant, because a transplant can have some mortality associated with it. Some centers still do cord blood transplants. These are technically more difficult because they are slow to engraft in patients, and we don't do it simply because it's really a bit of a hassle. I often get asked that if they have saved their child's cord cells, would that be of any use? Well, basically, no. It's a genetic defect, which means a child's saved cord blood doesn't help anybody at all, and those saved cells shouldn't be used for others. What other kinds of transplants are there? So there's a new kind of transplant called a haploidentical transplant, which means that we are now able to take the cells from the parents. So you might ask that the parents are thalassemia carriers themselves. How does it work? Well, to be honest, even if they're thalassemia carriers and we do a transplant from them, it means we change them from a patient who's got thalassemia disease to a patient who's only a carrier, and which means that they don't need any more blood transfusion. I've just put up the overall survival and event-free survival figures out there, which is to say that nowadays with all of these three types of transplants, we kind of are able to achieve a success rate around about the 85% for most of our patients. So because we are talking about BMT, I'll just talk a little bit about what is BMT very briefly. But if we talk about BMT in thalassemia, we need to know this thing called a Pesaro risk group. And what is a Pesaro risk group? So this is a way to kind of evaluate and estimate what the survival is going to be for a patient post-transplant. And it depends upon looking at three risk factors. What has been the quality of the chelation? Does the patient have a large liver? Is there any liver fibrosis on a liver biopsy? And should a patient have all three of these risk factors, he is said to be a Pesaro class 3, which means for somebody like this, if we do a transplant, the chances of him actually not surviving a transplant is almost 20%, and a success about 60%. Lesser the number of risk factors, the better is the outcome. So which means that we try and see that if we can get the transplants done on patients who has had somebody who's in Pesaro risk group 1, because these patients would have a survival of more than 97%. We, however, have started to cheat a little bit with these figures, because what we now do with our transplant patients is do hypertransfusion, a lot of chelation to actually get the liver sizes to come down. And with the newer protocols, almost all our patients seem to have an outcome of around about 80%. At the end of this presentation, I'll be sharing some data, and you're welcome to query me on that. So what do we exactly do in a transplant? So first step is that it's like preparing the ground for a crop. So which means first we need to get rid of the defective bone marrow in this case, which we do either with high dose radiation or high dose chemotherapy, which in a cancer case would destroy the cancer cells. In a thalassemia, it would destroy the defective bone marrow completely. Once that's done, we would be collecting the healthy marrow from a donor, which will be usually a sibling, rarely a parent. And this is what we do in a theater. We collect the bone marrow from the posterior iliac spine from both sides. This is my adult colleague, Samir, and the two of us actually do this in tandem, both of us collecting the marrow from the posterior spine one after another. It takes about 2 to 3 hours. And once we've collected, we can quantify how much live stem cells we've collected. And then that is actually infused. Sometimes we can collect the healthy marrow from a donor, and this we can collect if we are doing a parental transplant, a haplo. They don't actually like giving marrow, so we can collect the stem cells peripherally. So you can see this gentleman out here. We've got a neckline, and the blood is flowing into an apheresis machine. And what that does, it kind of spins the CD34 cells, which are the stem cells, separately in a centrifuge, pushes it up and collects it in a small blood bag. And once we get it, then we basically transfuse it back into the patient. And this is can sometimes be a little bit of an anticlimax when you think, oh my God, a transplant, what are we doing? All that we are doing is basically taking up these stem cells that are in that small blood bag out there and injecting it into a central vein into the patient. And once we have done that, we basically wait till the recovery happens, which usually takes about 14 to 18 days. But this 14 to 18 days is really the crux of our transplant success, because during this time, the white cell count of the patient goes to zero. Let me explain that. So, a normal white cell count is about 4 to 11,000. Right now, I have got 5 patients in my unit. The first patient there is this small 4-year-old boy called Mustafa Bora. I just did his transplant about 4 days ago from an unrelated donor. His white count today is 0, which means 0 as in 0. He has no counts at all. And I know that he will stay with a white cell count of 0 for the next 14 days. And I need to prevent him and protect him from viruses, bacteria, fungi, everything, which means that's why our units have to be super duper protected to protect any infections from happening. But once the cell starts to grow and they are fine, then we are able to send them both home. This was one of my thal patients, and this was the little donor that had donated the stem cells for the little girl. So that is where thalassemia is, but let's see where it's going to in the next few years. So if we have, and this is again a real case, that I had one of my patients who had thalassemia major. Parents were again very well to do, and they decided, they looked at all figures. They looked at the figures for matched sibling donor transplant, unrelated donor, and haploidentical. And they came back and said that, I know, and your research says that a matched sibling donor is the best chance to cure my child. So what we normally say, fine, so you go for another child, and when the child's born, we'll be checking whether that unborn child, make sure the child doesn't have thalassemia major. But after the child's born, we'll be checking whether he or she is a donor. They said, can we do something further? And yes, it's possible nowadays, because what we can do is that if parents don't want to take that chance that the next child may not be a match for the patient, or we don't want to go through the whole process. I have a pregnancy, and after pregnancy, you tell me whether that child has thalassemia major or minor, and then I have to have an abortion. And it's a terrible thing for asking any parent to go through. For somebody like this, we can offer a pre-implantation genetic diagnosis, which means that the parents go through cycles of IVF, the eggs are fertilized in a petri dish, and the embryologist can actually then look at the fertilized eggs themselves and see which ones do not have any copy of the thalassemia gene at all, and only implant those eggs. So which means it's almost guaranteed that the second child will be thalassemia free. Can we take it one step further? And yes, we can, because now the embryologist can not only look at those fertilized eggs and say which ones do not have any thalassemic genes, they can say which ones are genetically HLA identical to the first patient, which means that after 9 months, we have the second child who's thalassemia free and a complete match for the first child, which means we can collect the cord stem cells, or we collect the marrow after 1 year, 10 kilos, and we can have a successful transplant, which is possible, has been done in Thailand, in Israel, and we have done it in Bombay as well. I have 2 patients of mine who were going through it. The first one went through about 6 cycles of IVF and collection of eggs. And then suddenly we found an unrelated donor, among our doctors community, and they went in for an unrelated donor transplant. The child's doing well. The second lady is still going through it. It's a laborious process, but the end result can be quite magical. Is there any other new drugs? I've been talking a lot, and the next part can be a little bit boring. So I would ask to excuse me if I sound very, very boring. I'm just going to say that there are some new drugs that are coming through. And there are two of these two class of drugs. One is called an activin receptor trap genes, trap drugs, which basically inhibits the pathway that causes more red cell destruction and promotes late stage erythropoiesis. Two of these drugs are in clinical trials at present. One is called sotatercept and the next is called luspatercept. The luspatercept has very recently, last year, has had an approval for treatment of transfusion dependent thalassemic adult patients by giving them one injection every 3 weeks. How does it work? So it basically stops the ineffective erythropoiesis, and it helps the red cells stay in for a longer time. So which means with luspatercept, we have less transfusions. So if a patient used to have a transfusion every 2 to 3 weeks, with this drug, the duration in between transfusion goes up to 5 weeks, 6 weeks. So he does not become transfusion free, but the number of transfusion that he needs goes down. This is the biggest study that has been done for it, which showed that there is a reduction in transfusion burden for the majority of patients. The majority of patients needs 1/3 less transfusions. I won't go into the next three class of drugs, which basically are, I mean, just to say there are new drugs coming in, but I'll talk about a little bit about something that everybody is very interested about, which is gene therapy. So, and to be honest, we are also very interested in gene therapy. So what is gene therapy? So if we talk about what is a transplant, and this is what I said, that when we do a transplant, we collect cells from the bone marrow or peripheral blood, or maybe cord blood. We give chemotherapy to the patient, and then we basically have a transplant happening. Now, this is called an allogenic. In autologous, we collect the patient's own stem cells. Now, with a gene therapy, after these stem cells are collected, the genetic defect is corrected by using a viral vector. And these same stem cells are given back to the patient after destroying his own marrow with chemotherapy. And this is what a gene therapy is, which means that some of the steps are common. We still need to collect cells from the periphery from the patient. We still need to give him more chemotherapy, but with the gene therapy, we should have less complications. We don't need an outside donor. We don't have problems of graft rejection, and we should have less graft versus host disease. A stem cell transplant is very tried and tested, but gene therapy is the way of future. And I think this can really change the way we treat transplant patients. So this basically is what we do. We collect the stem cells. After collecting the stem cells, we send it off to the lab. The lab in a petri dish will correct the genetic defect there. The cells would be coming back to us in a bag. And then after giving chemotherapy, we will give those cells back to the patient. And what would happen is that post that the defective cells would go in there and more newer cells will be made. So whereas a patient in the past would not have made any red blood cells, post gene therapy, red blood cells would be made. It's kind of relatively simpler, but there's a lot of things associated with it. The majority of the problems is that um, the cost of gene therapy when I last looked at it was almost about 7 CR per patient, which means though it's a very exciting field to be involved in, till it becomes more easily available, we probably are still looking at standard therapy and a transplant as how we deal with these patients in the future. So I kind of promised that I'm going to tell you a little bit about our unit. So we started our transplant unit in 2010. In 16, we increased it to a 12 bedded. Next year, we're looking at a 14 bed. It's pretty good unit. We have isolation on-site blood bank. We also do a lot of HLA typing that's done free with support from DKMS. And we kind of like every year we are increasing the number of such HLA typing that we are done. So this year we were supposed to have been doing about 1,500, and of course COVID hit us, so we really haven't done much. Thalassemia transplants are done either free or at minimal cost to patients because of our partnership with an NGO partner. So which means that this part of our work is actually very satisfying. So if you look at what work we have done, the majority of the transplants in our unit is pediatric, and that I'm quite proud of. I've just done a shade under 100 transplants so far. So ideally by next week, we would have finished 100. And these are the patients we have transplanted: thalassemia major, multiple myeloma, AML, ALL, the whole gamut of patients. And what kind of transplants in the pediatric age group have we done? As we said, majority is thalassemia major. Then comes the malignancies, relapsed ALL, AML, neuroblastoma, few aplastic anemia, and everything else takes part in it. So thalassemia specifically, we just analyzed 36 patients that we have transplanted. A few of them had their transplant very recently, so we did not look at that. So our overall survival is 96% with an event-free survival of more than 80%. And 27 of those were sibling donors, 4 were unrelated, and 5 we did transplants taking the cells from the father. We had one patient whom we lost in our entire series till date, and this is one patient who had very severe GVHD. We had 3 graft failures, not 2. 2 of them have had a successful second transplant, and we are taking up 1. So we kind of like to think that our thalassemia data is basically good. And I'll end with this slide that about unproven therapies: thalidomide, wheatgrass, and various magicians who can say they can cure thalassemia. I will leave it to them, but certainly for a patient, that's not something I would be asking for. And with that, I'll end, and thank you.
Thank you, Santanu. It's an excellent presentation. Deepshika?
Yes, sir. So can we take up some questions? There's a lot of questions.
Excellent. Please.
Do we have time for that?
Yes, I have lots of time. It would be a pleasure.
Thank you so much. It was a really a great presentation, very crisp, very nice. So we go to the questions. This is from Dr. Shubhomoy. Role of Nestrov in the community. He's probably asking for the screening.
Yes. So certainly if you are in the community where you don't have access to HPLC or any other newer, certainly you absolutely must be using it, and you should continue to use it.
This is from Dr. D.
Yeah, please.
The next one is from Dr. Agarwal, DN Agarwal. What is a P-peak in the HPLC?
What is the?
P-peak. P as in Punjab, P-peak.
Okay. So if it's the P for a hemoglobin D Punjab, then basically when you look at it, that's when, to be honest, I'm more at the clinician side than at the lab side. So I mostly leave it to my colleagues in the lab to look at it. But when you're looking at thalassemia, all you need to look at is hemoglobin F and hemoglobin A2 to decide whether you are dealing with a thalassemia major or a thal minor.
Okay. The next one is from Dr. Prashanto Chaudhary. 2 questions from him. The first one, role of antiplatelet agent post-splenectomy in case of thalassemics.
Antiplatelet agent post-splenectomy, usually we don't put them on any antiplatelet agent. Post-splenectomy, the main thing to do is basically make sure that you've given them vaccinations against capsular bacteria. Ideally, keep them on an antibiotic prophylaxis. A penicillin agent will be great. And with our patients, usually we send them home with some antibiotics to say that if you have a fever, start taking it straight away. So we don't.
Okay. Is renal Fanconi syndrome common as a side effect of deferoxyrox? Any comment on that?
Deferoxidox, renal Fanconi, I have not seen, but yes, you should be watching it for renal. So the major side effect with deferoxidox really remains gastrointestinal. The second is renal toxicity can be seen. So I haven't seen personally, but I mean, certainly it has been described in the literature, but practically and pragmatically, not so many patients.
It's practically a safe drug, I would say, and
Yeah.
some transaminitis also, which is usually reversible post stopping the drug.
I would agree with that. I mean, out of these three drugs that we have, deferoxidox really is the safest agent that we have so far. And I feel very confident keeping my patients on it without doing too many tests, really. I mean, unlike
Exactly.
Kelfer, if you put a patient on Kelfer, I have a
Exactly.
little worry that look at whether this patient's going into agranulocytosis. But with this,
Santanu,
ah,
is there a difference between the policies of USA and Europe?
hmm,
In USA, they try to use more of the Firacirox, but
correct.
in Europe, still they are more in favor of desferrioxamine. Is that right?
That is
Hello.
absolutely right to a certain extent. So
Hello.
when we were working in the UK, uh, they still were relying on oral agents. And that was because the track record of desferoxamine was so good that they really didn't feel a massive need to move over to oral agents. So when deferoxirox came, the Americans were the early, they actually you put all of their patients on deferoxirox first, whereas UK, still a vast majority are on desferoxamine. Having said that, if you have a patient who has a high ferritin, which is not getting adequately chelated with deferoxidox, I also would actually go back to giving them infusions of desferoxamine to get that iron to come down more effectively.
So, do you have trouble accessing desferrioxamine these days? Like, it's difficult to access the drug.
You are absolutely right. I mean, the production of it seems to kind of like being a little stop and go. And again, your contacts with Novartis sometimes works
Yes.
wonders. And the second thing that works wonders is basically if your NGO partners can influence, put in some influence for them to actually get it for your patients.
Okay. So, the next one is from Dr. Diptayan Das. He says there's method of transfusing PRBC blood through 50 cc syringe instead of directly from the blood bag. Is it a correct method?
I haven't heard that. Basically, what we
Ye-
would transfuse is basically just from the blood bag, we would just either do that drop count and transfuse, or if needs be through an infusion pump. But I mean, I would just say that you don't really need to use a syringe and infuse. The only time we use a syringe to infuse any blood products is when we are using stem cells, and there's a reason for that. So if we are getting stem cells that has been preserved and then subsequently thawed, so stem cell preservation is done with a compound called DMSO before freezing. Now, once we thaw it, as soon as it gets thawed, it starts to break down the stem cells themselves. So that's why post thawing we are quite aggressive to use a 50 ml or a 20 ml syringe and inject that. But in the
Yes.
routine thalassemia care, when you are just getting the patients in for transfusions, I don't think you need to use a syringe to pump blood into them.
All right. The next one is from Dr. Dalbir. Is the dose of blood transfusion dependent on the hemoglobin level or is it fixed for all children?
No, it's not fixed for all children. I mean, to be honest, there are two ways to do it. You can either, if somebody is at a, so how do you decide how much blood to give? You can look at what is your ideal blood hemoglobin percentage that you're looking for and what is your current and measure the difference. If you're looking at achieving a hemoglobin of 12 gram percent and your patient has 8, so which means the difference in 4. So that's a difference, multiply by the weight, multiply by a factor of 4 gives you the amount of blood you want to give to the patient. So that's one way to calculate it. The second way to do it in a pragmatic way is that when the patient comes in into the transfusion center, you measure what is the pre-transfusion hemoglobin percentage. If it is something like 10, then you know everything's fine. You tell him to come back for the next transfusion after about 2 to 3 weeks. 2 3 weeks, certainly 3 weeks should be fine. And on the next time you give him a transfusion of 15 ml per kilo. So that's where a fixed number comes in. But if you find that he's come in and he's got a hemoglobin of 6, then even if you give it 15 per kilo or 20 per kilo, it will not be adequate. So for these patients, either you calculate exactly how much you need to give and you give that, or you go to a maximum of 20, but bring that patient back not after 3 weeks, but maybe after 2 weeks or sometimes even after 1 week, and give a second transfusion to achieve the higher hemoglobin desired.
Okay. Next is from Dr. Shubhamoy. Is portal fibrosis reversible after transplant?
If you have portal fibrosis, it will not be reversible no matter what you do. What will be reversible, that if you find that you've got an iron overload on a liver biopsy, if you do very good chelation and you follow it up with T2 star MRI, you would be able to reduce the liver load. But once you have end stage damage, I don't think that can be reversed.
The next one is also from Dr. Shubhamoy. Can patients of thalassemia with massive splenomegaly develop esophageal varices? Have you seen any?
I personally have not seen it. Esophageal varices would be more when you have bad portal hypertension. So portal hypertension and then you get into splenomegaly, that's different. The reason that thal patients get massive spleens is because of extramedullary hematopoiesis. So I haven't seen them getting into esophageal varices. If they have it, then I would actually look at whether they have a massive portal fibrosis, whether they have portal hypertension, whether something like that has happened to cause esophageal varices. So then those are the patients that we need to look further to see why that has happened in that patient.
Okay, this is from Dr.
There was a question from Preeti Khemka.
She has asked, how soon can we do the HPLC? How early in life can we send the HPLC for a baby?
Okay. So it depends, because we can't really do it immediately after birth. Immediately after birth, if we do it, all we have is the fetal hemoglobin that will come up. So which
Can I interrupt?
Yes, sir.
If there is no HbA in a neonatal blood, so it's more likely that this will be a thalassemia. So that's the only situation that thalassemia beta thal 0 or thalassemia major, if you don't have any adult hemoglobin, then it is very likely that this patient is having thalassemia.
Absolutely.
Also, we can do the parents, we can do if it is very early.
Correct.
So what about thalassemia intermediate?
The parents can be carrier, but that doesn't mean the baby will have a thalassemia.
No, if both the parents are carrier, then it's there's a fairly chance. What about thalassemia intermediate?
So thalassemia intermediate is the more difficult one. So if it's a thalassemia major, as Apurvada says, that's no hemoglobin A at all, then it's most likely that it is thal major. With an intermediate, what will happen is you'll have to wait. The earliest that I would say is do the testing at about 4 to 5 months, not before, and check what the hemoglobin A2 is and see whether that is high to decide whether your patient has thal intermediate. But then thal intermediate is never, thal intermediate you basically would be diagnosing on the transfusion requirements. So by the time you find out that the child's needing transfusions, getting there, and then is when you would be doing a test. So again, about 4 to 6 months would be the earliest I would be thinking of doing an HPLC. But again, the whole problem comes that if the blood transfusion has been given, then the test becomes not very significant.
Right.
I have a question which is very funny maybe. Suppose I have given a blood transfusion to a baby, or someone has been given transfusion and then comes to us. Can we calculate back that depending, a normal thalassemia carrier is not going to give the blood, or not a thalassemia major is not going to donate the blood? So can we have a calculation from where we can calculate that this patient is really having a fetal hemoglobin high?
It's a very interesting question. I can understand where you're coming from, but I don't think anything like that is what we are doing in a pragmatic way right now.
No, but I'm saying that the patient has already been transfused in a peripheral center. They
Correct.
have come to us. The baby's age is 4 months. And see, if the baby has received a blood, his fetal hemoglobin must not be very high because he is not a thalassemia, not a thalassemia patient is going to donate the blood. Am I right?
So usually though, so I mean, a Thal minor might donate a
Thal
blood.
minor, if
Yeah.
it is Thal minor, the percentage of thalassemia HbF will be very low.
Will be very low. It won't be very
And
high.
a patient who is presenting at the age of 3 or 4 months will have a very high fetal hemoglobin.
Would have a very high fetal hemoglobin. Agree.
So if at 5 months, if I get that, even after the transfusion, if I get a HbF of 50% or 40%, so that is likely to be a thalassemia.
Well, likely, but I mean, the main question is whether that's thalassemia major, we usually say with absence of hemoglobin A. So on an HPLC, we
So
can...
I think we can go in for a genetic diagnosis in these cases.
No.
Like we can guess,
Genetic
but we
diagnosis
can
is costly.
confirm.
Genetic diagnosis is costly, but since
So
the
we
patient
do
has
a
already...
parental screening
And that we do usually.
No, that we will do definitely. And also the patient's one. Because the parental, even if the parents are carrier, they are likely to have a thalassemia patient in only 25% cases.
Correct. That's
so you will have to calculate, and that I have done with my residents many a times, and most of the times, almost always we were correct.
Apurva, I think you need to get this together and publish it because I can understand
Not
where
that.
you're coming from.
I mean, we do face this situation because they come from the periphery with the transfusion.
Yes.
Now, this is a very practical and pragmatic problem because by the time they come to us at ICH or wherever, they already would have been transfused, which means we do an HPLC, we still find a peak for hemoglobin A. If you find a peak for hemoglobin A, we cannot see because thalassemia major. So if the way you're saying, if it works, that would really be the best.
Okay. The next question is from Dr. Ognimita. How long to continue antibiotic prophylaxis post-splenectomy?
Lifelong. You can't stop. You can't stop. It is a
There was a question that antithrombotic therapy, do you give aspirin after post-splenectomy?
I
think he replied that.
We don't actually. Just a second, Apurva.
Okay. Call from wife.
Sorry. I don't know, Apurva, because we don't. I mean, there are two things. One is that we don't actually, none of our thalassemia patients, we are advocating a splenectomy nowadays. So compared to how things were about 10 years ago, where most patients would inevitably have a splenectomy, nowadays we seem to be able to, with good management, try and get by with proper chelation, proper transfusion. We don't need to take them to a splenectomy. But the older patients who already have had a splenectomy, we don't find any of them are on antithrombotic agents at the moment.
No, I'm not talking regularly. What some surgeons do immediately post-splenectomy, immediately post-splenectomy for a couple of weeks.
Yeah,
that's practiced by many surgeons I have seen.
Again, I can't actually...
Because that's the period they have the thrombocytosis.
That will be when you do it and all the platelets will come back into the circulation and will have... So it makes sense to do that. I'm not sure what the current recommendation for that is, so I would not be able to answer that.
The next one is from Dr. Rajiv Sinha. Do you do genetic tests prior to starting Defera Zyrox?
Genetic test for thalassemia or... I mean, the...
I think he's talking about some pharmacogenomics. I'm not sure.
Not
Dr.
really.
Rajiv Sinha is there?
এই দীপাঞ্জনার একটা কোশ্চেন আছে, দেখো দীপাঞ্জনার একটা কোশ্চেন আছে, দীপাঞ্জনা
Panjana.
তত্ত্ব। It's about genetic, I think.
I'll check in the chat box.
Next time we will have a session on a non-transfusion dependent thalassemia.
That is very interesting.
Yeah, I wanted to ask that, sir, what is the role of hydroxyurea in case of E beta thalassemia? What's your experience, and
We don't
what's
use
the
it. So until and unless somebody puts forward a proper trial to say, unlike non-transfusion dependent thalassemia, that's different. But when you have thalassemia major without anything else, I don't think hydroxyurea has a role in that. Sickle cell disease, certainly I would put everybody on it, but normal thal major patients, we don't put anybody on it. Now, people are interested in hydroxyurea, people are playing around with thalidomide, with wheatgrass oil, but to be fairly honest, until and unless there is a good research that comes through or somebody is doing a study on that and showing good results, I would then like look into that.
What about decitabine? Decitabine. That's a new drug.
That's a chemo drug in thalassemia major.
Yeah. They are using it's a drug from 5-azacitidine.
Yeah.
People used to use 5-azacitidine because it has a lot of side effects.
Correct.
The newer drug is the decitabine, just to stimulate the bone marrow.
Haven't heard that. So if I look at, so it's probably coming again from the MDS world, the adult myelodysplasia world. So the new drugs that are coming through are the ones like luspatercept and the others. So the way they are all working is in the same way, that they kind of like promote hemoglobin synthesis. So decitabine in thalassemia, I haven't heard. Luspatercept has got an FDA approval. So maybe there's a single study.
There are some suggestions that it's pushing the fetal hemoglobin basically, but not routinely used. It's a chemo drug as such.
Correct, yeah.
And Dr. Rajiv Sinha has commented on the genetics question prior to starting Deferra-Zyrox. He wants to know pharmacogenomics for toxicity, for monitoring of toxicity. Do we do any genetic tests before starting Deferra-Zyrox?
Not at all. Absolutely not. It's a very, very safe drug. We've used it for thousands and thousands of patients. I think I would not like to do that. If this is my nephrology friend Rajiv Sinha that's asking the question, then
yes, absolutely.
Then I'll have to ask him exactly what is in his mind for him to ask it, whether he's looked into something.
He had a child who developed acute liver failure and AKI. Probably was on this drug, so he is asking about this.
No, I would.
That's a stray incident.
Just like Steven Johnson syndrome, and carbamazepine, where you do the genetic testing beforehand to see that whether the patient is more prone to Steven Johnson syndrome or not.
Right.
HLA association.
Okay, okay.
I don't think it's
so the last
done, but please.
Dipanjanaর একটা কোশ্চেন ছিল।
আমি দেখছি স্যার। আচ্ছা, okay. One is from
many a times the HPL
from Dr. Agnimita.
Yes, please. Sorry.
Okay. Yeah, go ahead, sir. From Dr. Dipanjana, the question is, depending on HPLC, we can take a decision whether to do a sequencing for hemoglobin P gene. At certain times, we need to do the MLPA where we can find the deletion.
Yeah.
And also Sanger sequencing can be done, which is not too costly. So it's more like a comment rather than a question. You would have any?
It's a very valid comment.
Comments on
basically, what's happening is that we are all very aware of the drawbacks of an HPLC, but still it's a good screening test. But if you ask anybody that how we would be diagnosing more and more accurately, then I think doing genetic test either by looking at either a Sanger sequencing or an MLPA and looking at it in more depth will be the way forward for all of us, for most of these diseases, to be honest.
Santanu, last question. Last question. If the I know your wife is calling you for dinner. So if both the parents are carrier, and what is the chance that the baby can have it thalassemia?
25.
If both the parents are normal, what is the chance that the baby can have it thalassemia?
It would be rare, but it not be unknown. So this can be a fresh de novo mutation.
Yeah. And
but there will be a few. Sorry.
If mother is a carrier, father is not, but the baby develops thalassemia. One may be that the father is not the real father, but if the father is real father, what is the chance that the baby can be thalassemia? Mother is a carrier, father is normal, and the parents' family, father's family is saying that this is not possible. So they are doubting the mother. So is there a chance?
So from the genetic viewpoint, then we'll have to say that he's inherited one defective copy of the gene from the mother. And due to whatever reason, the other normal beta globin gene that he has inherited from the father has basically either got a point mutation or it has been suppressed due to whatever reason. So it is not being expressed in the child, which can...
But it can have. The child can have thalassemia.
It can happen, but this will be where all our geneticists will need to go in and look into the child's gene in greater depth to see why and how this has happened. But I would say your first thing to look at will be that look at the HLA typing of the whole family to make sure things are the way it should be. And that has happened more than once with me. So, yeah. But yes, but you can have non-expression of one of the genes, and should it happen that you have a non-expression from a paternal side and you inherit the defective maternal gene, then theoretically at least I can see it happening.
Yeah.